Rajarajeshwari Medical College to come onto the stage. Thank you.
For giving me this opportunity. Let's go ahead with the talk, medical management of glaucoma. As you all know, intraocular pressure, that's the only modifiable risk factor in glaucoma. All the landmark trials have shown that therapeutic IOP reduction does help in glaucoma. So before we treatment, all of us know that we have to understand target IOP, which is an estimate of mean IOP obtained with treatment that is expected to prevent further damage. So when we talk about the drugs which are used in glaucoma, it is divided into which decreases the production, which increases the outflow, which can again be divided into trabecular outflow and increase in uveoscleral outflow. Now, when we intend to get a 20 to 30% reduction, beta blockers are always a good choice, which is very, economically selective brand also, and beta blockers which can be non-selective beta blockers which can be used. Some of the contraindications being when the patient has severe COPD, bronchial asthma, if they have any kind of cardiogenic shock, and the ocular side effects minimal, but when seen, you have to talk about epithelial keratopathy and decrease in the corneal sensation. One point to be noted here is efficacy of these drugs, this topical beta blockers, may reduce if the patient is already on systemic beta blockers. Other drug, which is a favorite most of us, is prostaglandin analog, which is a single dose, preferably at night, which also gives a 30% reduction in the intraocular pressure. Some of the points to be noted here is we should not be using this prostaglandin analogs in cases of inflammation. Now, most of us prefer to use this brand considering the single dose, which can increase the compliance of the patients. Notable side effects of this include conjunctival hyperemia. As you can see, there is a periorbital pigmentation. This is a classic side effect of a long-term use of prostaglandin, which is called as prostaglandin-associated periorbitopathy, the deepening of the sulcus and loss of periorbital fat, and this is lengthening of lashes. And there has been instances of reactivation of viral keratitis, and cystoid macular edema has been noted in some cases. So when we need more than 40% reduction, we always have to think on something called add-on drugs or a combination drugs. Now, some of the add-on drugs which we use are alpha-2 agonists, which causes a reduced aqueous production and improves the trabecular outflow also. This is usually used in prophylaxis of acute IOP spike, which we use as brimonidine. Apraclonidine is not available in India. It can be used as a neuroprotective drug also. Now, some of the notable points regarding alpha-2 agonists include these are contraindicated in young children, and if they have noted allergy of alpha agonists. And some of the ocular side effects, if you can see, there are these typical follicular conjunctivitis, severe periorbital dermatitis, and something called brimonidine-induced uveitis. This is something which is of late coming more and more common. So when you see these KPs, which are small white KPs, brimonidine, it might be due to that also. And of course, the systemic side effects, as it crosses the blood-brain barrier, you can get fatigue and somnolence. Other add-on drugs include carbonic anhydrase inhibitors, which is dorzolamide and brinzolamide. Brinzolamide having less stinging sensation when compared to dorzolamide, 2 or 3 times can be used as a single or as an add-on drug. Now again, these carbonic anhydrase inhibitors also can cause periorbital dermatitis, and other side effects of systemic side effects are severe bitter taste. Many a time patients stop using these drops because of these bitter taste, and as systemic side effects like paresthesia is seen while using topical drug as well. The new kid in the block, Rho kinase inhibitors, which is netasudil and ripasudil. Some of the notable side effects which is commonly seen is this honeycombing of cornea verticillata, and severe conjunctival hyperemia. All of you know fixed combination drugs, all with timolol, some with brinzolamide and brimonidine. And we have the triple combination drug, which includes the brimonidine, timolol, and brinzolamide combination. Cholinergic drugs, pilocarpine, most of us use in acute angle closure and in glaucoma, anaphakia, and pseudophakia. The side effects being severe reduced vision due to the accommodative effect, and some of the systemic side effects are headache and intestinal cramps, which is seen quite often. Carbonic anhydrase inhibitors, we use left and right acetazolamide, but mind you, there are certain contraindications, sulfa drug, severe kidney dysfunction, all these patients better to avoid. And if the patient has any kind of a gastrointestinal disturbances, use with care. Paresthesias, tinnitus, these are some of the common side effects which we note with carbonic anhydrase inhibitors. Hyperosmotics, in acute cases, we can use glycerol or 20% mannitol, which is given as a slow intravenous injections. Some notable contraindication being severe cardiac pulmonary edema, then these hyperosmotics should be avoided. Special situations, I'm not going to the details. Brimonidine is the only drug which is in class B group, and avoid all medications during the first trimester. In the second and third, we can consider beta blockers, alpha agonists, and myotics. If surgery, usually it is performed in second trimester. Lactating mothers, beta blockers and alpha agonists avoid. Systemic can be used with caution. Topical carbonic anhydrase inhibitors, prostaglandins and myotics are reasonable choices. Other newer drugs in pipeline, netosudil with latanoprost combination, latanoprost bunod, and omidine PAG isopropyl. Of course, neuroprotective, various drugs are being studied and used wide over. And just 2 words about drug delivery implants. Durista, which is a bimatoprost implant, which is in the anterior chamber. Bimatoprost ring, which is called as beam ring, and other punctal plugs of travoprost punctal plug and an iDose travoprost. These are all in clinical trials. Thank you.
Thank you, Dr. Meena. That was a wonderful, concise presentation of a vast topic. So, moving on to the next speaker, Dr. Shorba Dinakaran from Narayan Netralaya will be talking on structure and function discord. I would request the members that they put the questions at the end of the session.
I think by the time she's getting ready, if
Yeah,
anybody
if
has a
there-
question with respect to medical management. That was very comprehensive, Dr. Meena, vast topic. So I think she's ready. So. Any questions? Yes, yes, please.
way of scheduling through the entire day? Is there any
Yeah,
specific?
what I do practically for my patients is that anything with timolol, like brimonidine and timolol, dorzolamide, brinzolamide with timolol, I give it earlier to 8 o'clock in the morning and earlier to 8 o'clock in the evening, and 12 hours apart. So I tell them, put it before 8 o'clock, say 7 a.m., 7 p.m. And the prostaglandin analog single one at 9 p.m. So if there is one more, like ripasudil or nitarsudil that you are adding, then it has to be about half an hour before or after the thing. It is easy for us to say, but a very tall order for the patients to follow. And in that regard, the triple combination is a huge blessing. So that has really helped in terms of giving many medications.
Thank you, ma'am.
Good afternoon, everyone. I'll be talking about structure function discord in glaucoma. So glaucoma is an optic neuropathy which is characterized by structural damage evidenced at the optic nerve head and retinal nerve fiber layer, which results in functional damage, which is evidenced by changes on the visual field analysis. Now, what happens when structure and function disagree? So we can have disc damage with good function, or we can have functional loss with no visible disease. Now, coming to pre-functional disease, now visual field loss is preceded by structural changes in the optic nerve head. A 40% nerve fiber loss results in a 10 decibel visual field defect. Thus, the retinal nerve fiber layer loss precedes the optic disc changes. So here we have an example of a relatively healthy-looking optic nerve, normal visual fields, but his OCT showed an inferior NFL thinning. So the question is, do we treat this sort of a patient, pre-perimetric disease? So let's look at the bigger picture. His other eye had a superior arcuate defect with the corresponding inferior NFL thinning. And going back to the eye in question, he has been under follow-up from 2021 up until 2024. And even though his fields have, and the OCT showed some amount of progression, so though the visual fields remained normal throughout the last 4 years, keeping in mind his young age and damage to the other eye, we decided to treat him. Now, coming to normal anatomical variation, so this is when there is a misleading relationship between the area of the optic disc and the volume of the neuroretinal rim. Here we have a large, healthy-looking optic disc, around 0.75 to 0.8 CD ratio. These are physiological discs, definitely do not require any treatment. But let's look at this disc instead. So this is a patient who presented with large optic nerves around 0.7. CD ratio, his disc area on the OCT is around 2.5 in the right eye, a large disc, a medium disc in the left eye with NFL thinning in both eyes. Now, the question is, do we treat this patient? His visual fields are normal, and considering the fact that he has no risk factors, no family history of glaucoma, a compliant patient, a radiologist himself, and his previous evaluations have been normal with a test been done around 5 years ago, we decide not to treat him but keep him under observation. Here we have another example of myopic discs in a 25-year-old high myope as well as a steroid responder, very suspicious looking optic nerves in the left eye particularly. His OCT scan shows superior thinning in the right eye and significant NFL thinning in the left eye. Now, do we treat him? His field tests were normal, and he's been undergoing regular fields over the last 5 years. Considering the long follow-up and the long follow-up for around 5 years, we decide not to treat him. However, keep him under close observation, especially since he has 2 risk factors, that is being a steroid responder as well as being a high myope. But of course, we do have the advantage of him working in an eye hospital and being being very compliant and with his follow-ups. Next, coming to congenital disc abnormalities. So here we have a field with a superior arcuate defect, and but if you take a closer look at the optic nerve, you see an inferior optic disc pit. So the question is, do we treat this patient? Now, in congenital optic disc pits, we usually don't get field defects, but whenever they do occur, they are most commonly arcuate defects or central and paracentral scotomas or enlargement of the blind spot. These are non-progressive and do not require treatment. Here we have myelinated nerve fibers, which are very strange looking optic discs, sometimes can be very suspicious. However, they are functionally normal and don't require treatment. Similarly with the morning glory syndrome or megalopapillae, don't really require any treatment. Next, coming to functional loss with little visible disease. So this can occur when you have a visual field test error. So this is a field at first glance, looks like a very suspicious field. However, if you take a look at the refractive error, the refractive correction is 5.75 in the right eye, and which has resulted in a rim artifact, does not require treatment, needs to be repeated with a contact lens. This is the classical cloverleaf pattern, which looks suspicious, however, does not require treatment. This can occur in the case of fatigue, a sick patient, or a patient who is disinterested, needs to be repeated, and as the patient's understanding improves, the learning curve also improves. This is a field effect which is the result of an erroneous refractive correction being placed for the patient, which disappears when the appropriate correction is placed. In this case, no correction. Does not require treatment, just needs to be treated appropriately or tested appropriately. This is a structurally normal disc. Next, coming to observational errors. Here we have small optic discs which can actually be mistaken for normal, particularly in the right eye. However, it has an inferior field defect in the right eye and inferior as well as an early superior defect in the left eye, corresponding NFL thinning in both eyes. A closer look at the OCT, the area of the disc area is 1.4 and 1.2. Small discs definitely requires treatment as well as observation. So all small discs are not necessarily normal. Now coming to other errors, this is an example of a healthy looking optic disc around 0.6 CD ratio and an inferior field defect. This was a 23-year-old who was on treatment with prostaglandin analogs for a month, but a dilated evaluation revealed a large inferior retinal detachment, highlighting the need for, or rather the importance of a dilated fundus evaluation. He definitely requires treatment, but by the right specialty. So in conclusion, we cannot expect exact agreement between structure and function, and significant disagreement should indicate that either one or the other is erroneous. No test should be interpreted in isolation and always correlate clinically. Thank you.
Thank you, Dr. Shoruba. That was an extensive coverage of structure-function discord that we see commonly. And I call upon Dr. Soumya Krishna.
Dr. Shoruba, that was a very nice presentation and very appropriate. One small point I would like to make, in your first case, where there was a small RNFL defect, a 10-2 field could be more probable to pick up a defect rather than a 30-2 or a 20-2. When you have a nerve fiber layer defect which is isolated like that, which is closer to the 3 o'clock or 9 o'clock, then the 10-2 can pick up. Many times where the 24-2 or 30-2 won't pick up the defect. So that's another indication of the 10-2, not just in advanced glaucomas, but overall a very excellent presentation.
Good afternoon, everybody. Today I thank BOS for giving me this opportunity. Today I'll be talking to you about perils of low IOP. Even though a low intraocular pressure is a desirable outcome of filtering surgery, the ocular effects of an IOP that is too low poses a risk structurally and functionally. So what is the definition of hypotony? Hypotony may be defined both statistically and clinically. Statistically, it is defined as 3 standard deviations below the mean IOP, that is around 6.5 millimeters of mercury. Clinically, it is defined as IOP low enough to result in structural and functional changes in the eye, leading to visual loss. So the incidence of hypotony due to filtering surgery varies from 1.3 to 30%. This is a wide range because of the difference in the surgical technique, the concentration and the duration of antimetabolites used. And hypotony is rarely low with glaucoma drainage devices, with around 0.4% in AGV and slightly more in valveless implants like BGI, which is 4.5%. MIGS carries much lower risk of hypotony. It is not clear which patient will develop the clinical signs of hypotony. Some patients are very comfortable even at 2 millimeters of mercury without any symptoms, whereas other eyes can, the symptoms begin to happen even at a pressures of around 10 millimeters of mercury. So what's the pathophysiology? It is mainly due to increased aqueous outflow, which is commonly due to bleb leaks, overfiltering bleb, rarely due to cyclodialysis, cleft and scleral perforation during a retrobulbar block or superior rectus suture in a soft eye. And the other reason being decreased aqueous production due to iridocyclitis aqueous suppressants and the toxic effect of mitomycin on ciliary body. Sometimes it can be a combination of both increased outflow and decreased aqueous production. So with GDD, the main causes are insufficient end plate encapsulation resulting in overfiltration and reduced production of aqueous secondary to inflammation. Very rarely it is due to a cyclodialysis cleft, which can occur inadvertently during TRAB and rarely in mixed procedures like goniotomy. So hypotony itself causes inflammation leading to a breakdown of the blood aqueous barrier and decreased aqueous outflow, which and causes a self-perpetuating cycle of hypotony. So the risk factors are male myopic young patients, use of anti-fibrosis agents, elevated pre-op IOP, previous vitrectomy surgery, and uveitis. So hypotony is classified as early post-op hypotony, which is seen earlier than 2 weeks, and most commonly occurs due to bleb leak, due to a buttonhole or conjunctival retraction, and overfiltration. Usually they are mild and transient, and they resolve with conservative management. The other rare causes are cyclodialysis clefts, ciliochoroidal detachment, RD, and perforation of sclera. So late post-op hypotony is mainly due to a dysesthetic avascular thin bleb causing overfiltration. Then again rarely due to cyclodialysis cleft and ciliary body detachment. These are more serious than early hypotony, and prognosis depends on the duration. So coming to the anterior segment complications, there's a chicken wire appearance of the cornea due to endothelial dysfunction leading to corneal edema and striae. There will be a shallow flat AC which can give rise to pus. Chronic hypotony gives rise to cataract, and there is due to choroidal effusion, there can be a forward movement of the lens iris diaphragm. Hypotonic maculopathy now it's seen in around 20% of the cases, especially after introduction of antimetabolites. Again, the risk factors here being a young myopic male. Sorry, this. So it causes failure of the bleb. Hypotony also results in failure of the bleb because of increased inflammatory mediators in the aqueous and reduced aqueous egress through the bleb, increasing the subconjunctival fibrosis and scarring. So pathophysiology of hypotonic maculopathy, there is a decrease in the volume of circulating aqueous, which leads to decrease in anteroposterior axial length of the eye, inward displacement of sclera, redundancy in the choroid and retina, leading to chorioretinal folds, and the thick perifoveal retina is thrown into radial folds around the fovea, clinically seen as macular striae, RP changes, and retinal vascular tortuosity. So choroidal effusion, here choroidal fluid accumulates in the potential space due to increased uveoscleral outflow and lack of sufficient IOP to maintain the closure of the space. Small peripheral effusions are usually asymptomatic, but large ones can extend posteriorly into the macula, and anteriorly they can displace the lens iris diaphragm also. And it is seen in around 20% of TRAB and around 7 to 8.3% of glaucoma drainage devices. Risk factors being ranophthalmos, Stooge-Weber syndrome, and patients with raised episcleral venous pressure. Sometimes the accumulation of the blood in the suprachoroidal space happens due to disruption of posterior ciliary arteries, resulting in suprachoroidal hemorrhages. The other manifestations being hyperopic shift in refraction due to reduction in axial length, anterior bowing of the lamina cribrosa giving rise to optic disc edema, progressive optic neuropathy. Very rarely, ocular decompression retinopathy can happen due to a sudden iatrogenic decrease in the IOP. Very rarely, even retinal detachment is seen. So clinically, we have to, the main things are, usually the patient is asymptomatic or may complain of reduced visual acuity. So Siedel's test is an important one. Then corneal striae. Sometimes we may miss an overfiltering bleb due to the area of chemosis. So we have to look for microcystic changes. Then grading of the shallow AC and gonioscopy, which has to be done even though it is difficult in a shallow AC, soft eye. So signs, pseudophacodonesis, phacodonesis, then signs of intraocular inflammation, cyclitic membranes and synectae and cataract due to chronic hypotony. fundus I have already. So investigation, CDLS is a main test. B-scan, UBM, fundus photo, FFA, SDOCT, very important because it can pick up early signs of hypertonic maculopathy in a clinically normal looking eye. So management in early hypotony, it's usually conservative. Large with a small anterior leaking bleb, large diameter BCL, patching of the eyes, tapering of steroids, cyanacrylate glue, topical gentamicin, aqueous suppressants, cycloplegics, and topical antibiotics in cases of leaking bleb. So surgical indication for surgical treatment, visual deterioration, progressive shallowing of AC, corneolenticular touch, and kissing choroidals. Surgical management, large conjunctival leaks need a conjunctival advancement surgery or autograft. In case of incompetent blebs, bleb repair, scleral flap suture, resuture where it is due to overfiltration is due to loose sutures or if the sutures were cut too early, conjunctival compression sutures, and when there is a scleral flap necrosis, scleral patch graft. Cyclodialysis cleft, usually argon or diode laser, and for non-valve GDD, suture ligation or ab interno stent implantation. Draining of choroidal infusions in persistent hypotony with a posterior sclerotomy. So prognosis depends on the impact, etiology, and duration of hypotony. Transient hypotony usually has an excellent prognosis. Sustained hypotony due to secondary changes in lens, cornea, and retina can affect the vision. Chronic hypotony leading to phthisis bulba is very rare and occurs in eyes with severe damage or complex problems. Care should be taken in preoperative planning of the surgery. Set a target IOP, identify high-risk patient, examine the fundus for early changes of hypotonic maculopathy, and careful monitoring of the vision post-op. Tips, as we all know, leaks, careful use of intraoperative antimetabolites, avoid leaks, err on the side of tight scleral flap sutures, and releasable sutures to titrate the flow, delay the cutting of sutures when antimetabolites are used, and gradual control of IOP before surgery and intraoperatively. And in GDD, placing additional flow restriction sutures. So explore less options like mix. I think we are running short. Yeah, sure. Thank you.
Thank you, ma'am, for the. Yeah, it's a vast topic. I request Dr. Shilpa N. ma'am from Asta Super Speciality Eye Hospital to deliver her talk on secondary glaucoma management.
You should make sure at the end you titrate properly. Any audience questions on hypotony, please? I mean, till Dr. Shilpa sets up her.
And I think in these eyes, quite a lot of times we've seen the CDLs may not turn out to be positive because of the low IOP.
Definitely. So when there is low IOP and you do a CDLs, many a times because there is not much of aqueous there, the CDLs may be negative. So you should be a little more persistent. In fact, watch the eye for 1 minute or so. You keep watching it and you'll see that a leak comes. And if everything else points towards a leak and it's not there, even intraoperatively, take them to the OT, reform the AC and intraoperatively check CDLs, and you'll be surprised to see that the leak is positive. So CDLs test is an extremely important test. Do it on all your post-op patients, trabeculectomy, immediately post-operative, and even late when they are following up with a filtering bleb. Dr. Shilpa, please.
Thank you. Good afternoon, everybody. So I thank BOS Scientific Committee for giving me this opportunity to talk on management pearls of secondary glaucoma following various ocular surgeries. So as glaucoma specialists, we should be proud because all surgeons or all specialties look up to us because glaucoma is a complication, can occur as a possibility after any ocular surgeries. So the commonly done surgeries would be post-cataract, and then we have other specialties like post-VR surgery and post-keratoplasties. The most important thing is to identify the cause. What is the cause for glaucoma? So half the management happens in prevention, and then even if it happens, then we can manage it later. So during early post-operative period after cataract, we look for retained lens matter, blood visco, pupillary block or inflammation and correct it accordingly. In early post-op like between 2 to 30 days. It should be like look forward for pupillary block, malignant glaucoma, and steroid-induced IOP spikes. And late onset glaucomas, wherein you look for open angle variety and cynical closure, or a persistent pupillary block, or a fibrous or epithelial ingrowth. This would happen probably in ECCA eras. So with the advancement in technology and phacoemulsification, we don't see those complications right now. So the management, as I said, a prerequisite for prevention of postoperative glaucoma is thorough meticulous surgery, preoperative planning, and thorough meticulous surgery with adequate cortical wash and removal of visco and the blood. And pupillary block is a very simple procedure that can relieve the pupillary block and solve a lot of problem. Just needs a laser iridotomy. And in cases of when you suspect a malignant glaucoma with shallow chamber, uniformly shallow chamber, the diagnostic UBM will differentiate between the pupil block and the malignant glaucoma, thereby aiding the treating the cause. Usually the medical treatment suffices. In early postoperative period, we look forward for beta blockers, alpha agonists, and carbonic anhydrase inhibitors. Now we have the triple drug combination that was highlighted by Madam. In the late postoperative period, of course, when the inflammation has settled, still the prostaglandin analogs can be given, and caution should be exercised with the use of miotics and epinephrine group of drugs. So coming to the principles of surgical management, trabeculectomy with antimetabolites or with other adjuvants can be an option when we have a good mobile conjunctiva and the patient has a good vision potential with little or no ocular inflammation and no active neovascularization. We consider a glaucoma drainage implant when there is a scarring of the conjunctiva with moderate to fair vision potential with active inflammation and neovascularization. And laser for cyclophotocoagulation can be an option with a poorer visual potential and a scarred conjunctiva when there is no option for either of the filtering surgeries or the tube surgeries to control the pressures. So coming to the cornea surgeries, almost all the procedures can lead on to glaucoma, the most common being the penetrating keratoplasty and the most safest being the deep anterior lamellar keratoplasty. So the incidence varies between 9 to 30% in the postoperative period, early postoperative period, but the challenge is the surgical treatment in post-keratoplasty eyes is a challenge. 18 to 35% will have a late postoperative glaucoma, so the management is like as they follow up with the cornea surgeon, they have to follow up with the glaucoma surgeon as well. Penetrating keratoplasty is one of the most common cause of irreversible visual loss. Glaucoma following that is a very common occurrence because most of the times we see a clear graft, but then there will be a optic nerve changes due to glaucoma in the back. So management again depends on the risk factors and the cause, the indication for the keratoplasty. So we have all the risk factors here. So we have to be careful when the patient is operated for these cases. Another thing is when we have a tight suturing with long compression sutures and increased, there's a disparity between the corneal button and the donor site. So medical management again is a little challenging in post-keratoplasty because we have the ocular surface problems also coexistent and the glaucoma medications do alter the ocular surface to a large extent. So in a nutshell, we see that major risk factors are peripheral antracynic graft after aphakic and pseudophakic bullous keratopathy. And keratoconus, and when the keratoplasty is done for keratoconus and Fuchs endothelial dystrophy, there's a low risk for glaucoma, safer side. Medical and surgical intervention should be planned as deemed necessary. So after a brainstorming VR session, you have seen various oil, gases and injections put inside the eye. So we have glaucoma after VR surgery is a very common occurrence. So when we have a pre-existing glaucoma, all the more the patient has to be, the patient and the surgeon has to be more careful in monitoring the glaucoma changes and controlling the pressures adequately. Most common occurrences will be neovascular glaucoma, intraocular gas, liquid air, and the others would be PFCL and silicone oil as well. So yeah, luckily scleral buckling surgery has taken slightly backseat, so I would be just skipping the glaucoma due to this. And yes, vitrectomy is the most commonly done, And these are the commonest risk factors we see with vitrectomy intraoperatively. So coming to just management in a short after silicone oil, the most common thing we see is the pupillary block. The first preventive thing that they can do is just do an inferior iridectomy with the same vitrector. That would solve the problem, or you can do it in a post-operative period, laser iridotomy. And the late post-operative mechanism is because of the emulsified oil that we see is an hyperleon in this case, and this causes a lot of problems. And even if you remove the silicone oil, the glaucoma is intractable because of the emulsified bubbles that continue to obstruct the trabecular meshwork. And as we all know, gases are self-resolving, so you just wait for the gas, the maximum duration of the gas to resolve. In that period, the IOP should be maintained, and subsequently, it usually settles. So when the caution that you have to exercise is avoid air travel in these patients, because it just definitely goes up during the air travel. So this is the algorithm for the management in short after vitreoretinal surgeries. I think, thank you for the opportunity. If there are any questions, we'll take it at the end.
Thank you, Dr. Shilpa. Now we have Dr. Asha MS talking on beating the storm in NVG. She's a glaucoma consultant at Netradama.
I think Shilpa's talk, I want to add, one of the most problematic situation is post-corneal surgeries to measure the IOP. So we need to be very clear how we are measuring, and are we getting the right reading before we embark on any treatment. Same way silicone oil, it's very easy to tell our retina colleagues, tap the silicone oil. No, before, they will not like it, definitely. So before we decide that, yes, this acute glaucoma is due to an overfilled silicone oil, we have to rule out all the other causes. Many a time it is just a scleral inflammation which causes an increased episcleral venous pressure. So many times I've seen just pumping in anti-inflammatory drugs. I'm talking about systemic anti-inflammatory drugs. Once the scleral inflammation settles down, even the pressure comes down. So these are some of the points which I wanted to highlight.
I just want to ask one question to Dr. Shilpa. Does it really type of IOL is a risk factor for secondary glaucoma?
Usually right now we have all the posterior chamber IOLs, and well placed in the bag IOL should not be a problem unless when we place it in the sulcus, the hydrophobic IOLs, or which we place it in the sulcus, when they get decentered, they can be an UGH kind of an occurrence. Or the ideal IOL probably for sulcus placement is a 3-piece IOL, which
Definitely, Shilpa. Never place a single piece lens in the sulcus. It is a recipe for disaster. It can cause UGH syndrome.
Yeah, the 3-piece PMM has an angulation of 10 degree. That is an advantage for us.
Good afternoon, everybody. I thank BOS Scientific Committee for giving me an opportunity to speak on neovascular glaucoma. We all come across neovascular glaucoma as a devastating and aggressive form of glaucoma in our everyday practice. Managing and salvaging vision which is already compromised due to retinal disorders comes in the hands of glaucoma specialist. So, neovascular glaucoma by definition is a secondary glaucoma resulting from neovascularization of the anterior segment including the iris and the angle, and it is often associated with retinal ischemia. The other synonyms for this are hemorrhagic glaucoma, thrombotic glaucoma, congestive glaucoma or rubeotic glaucoma. And in coming to the history, Coates described it in 1906, and Coates saw that there is a past formation in neovascular glaucoma, and Weiss et al. Termed it as neovascular glaucoma. And coming to the etiology, there are various reasons for the development of neovascularization in the anterior segment, but the most important common reasons for neovascularization is the proliferative diabetic retinopathy, the retinal vascular occlusive disorders, and the carotid artery obstructive disease. Coming to the risk factors are hypertension, diabetes, mellitus, dyslipidemia, cardiac disease, and history of smoking. All these increases the risk of neovascularization in already compromised retina. Coming to the pathophysiology, the ischemic retina causes retinal hypoxia, which sets in the cascade of angiogenesis factors, and which diffuses into the anterior chamber, causing neovascularization. This is the pathogenesis that occurs. It's a cascade which forms the new vessels in the anterior chamber, including the iris and the angle. Stages of neovascularization are pre-rubeosis stage where the IOP is not increased and new vessels are not seen but actually documented on anterior segment angiography. Pre-glaucoma or rubeotic stage where tiny tufts of vessels are seen at the pupillary margin, and open angle glaucoma, here there is rise in the intraocular pressure with development of a fibrovascular membrane on the anterior surface of the iris and angle of the anterior chamber. And last stage is the angle closure glaucoma where contracture of fibrovascular membrane pulls the iris over the trabecular meshwork, forming the 360-degree peripheral anterior synechiae. A patient when they walk into the clinic with severe pain, headache, vomiting, redness, watering, diminution of vision and photophobia in the affected eye. On examination, we see that there is reduced vision, ciliary congestion, corneal edema, deep anterior chamber with flare, hyphema, fixed dilated pupil, and there may be NVI, NVA with raised intraocular pressure. With this condition has to be differentiated from primary angle closure glaucoma, uveitic glaucoma, Fuchs heterochromic iridocyclitis, eye syndrome, old trauma, or lens-induced glaucoma. So further investigations for eye, we have to do slit lamp biomicroscopy to see all these features, and gonioscopy is very important. It not only differentiates between the open or closed angle in neovascular glaucoma, but also we can see the previous surgeries that has happened. Silicone oil can be seen on gonioscopy, and FFA is done to see the CNP areas. OCT angiogram is done in people who cannot tolerate the dye. And B-scan ultrasonography is essential when the media is hazy. It can also pick up any intraocular tumors that are present. And systemic investigations is very, very important to rule out hypertension, diabetes, ocular ischemic syndrome, carotid cavernous fistula, uveitis, retinal vasculitis, and blood dyscrasias. All these investigations have to be done. Coming to the treatment, the medical management is to lower the high intraocular pressure by giving beta blockers, alpha-2 agonist, or topical or oral carbonic anhydrase inhibitors. We usually do not give prostaglandin analogs and pilocarpine, so because it aggravates inflammation. And topical atropine is used for cycloplegia. Topical corticosteroids is used to reduce the inflammation. Pan-retinal photocoagulation is the mainstay of treatment. It reduces the posterior segment ischemia. It also recovers the homeostatic balance between the pro-angiogenic factors and anti-angiogenic factors. It is done either using slit lamp or indirect laser. So PRP in diabetes mellitus is done in established cases of PDR. It is done either after giving intravitreal bevacizumab. And in CRVO cases, PRP is done only if we see 2 clock hours of NVA or NVI. And in ocular ischemic syndrome, PRP is indicated when there is retinal ischemia on FFA. In these patients, we also have to refer them for cardiology and neurology assessment. Vascular endothelial growth factor, it is still a controversial topic, but giving anti-VEGF factors prior to PRP or surgery, it decreases the post-operative hyphema and the number of post-op medications that are required to reduce the IOP. Surgical treatment is to lower IOP, especially in eyes with PAS and angle closure. The surgeries done are trabeculectomy with antimetabolites and GDD. Trabeculectomy, always use antifibrotic agents, either mitopycin C or 5-fluorouracil. The studies indicate that the success rate of trabeculectomy at 1 year was 62%, which reduced to 50% at 5 years. With the use of preoperative bevacizumab, the success rate came up to 90%. Multivariate analysis found that trabeculectomy was a primary inhibitor factor for recurrence of neovascularization. The hypothesis is that the increased post-operative outflow of the aqueous into the subconjunctival space may prevent accumulation of VEGF in the anterior chamber and prevent the neovascularization. And the risk factors for poor outcomes in trabeculectomy are PDR and persistent new vessels, younger age group, prior vitrectomy surgery, higher number of anti-VEGF injections, and delay in performing trabeculectomy. Glaucoma drainage devices, this is indicated in scarred conjunctiva, active inflammation, vigorous new vessel growth, and in failed trabeculectomy. It can also be taken as primary surgical procedure where there is a risk of failure of trabeculectomy. When the studies have been done, both showed the same outcome, but where the IOP is less than 21 millimeter of mercury was seen with the Barwelt glaucoma implant surgery. So we have to keep in mind that sustained elevated IOP during or after surgical interventions such as GDD or vitrectomy can snuff out the already damaged optic nerve. So the risk should be explained to the patient, and aggressive medical management of IOP preoperatively and perioperatively is very important to bring the success of the surgery. And last is the cyclodestructive procedures like diode transcleral cyclophotocoagulation, micropulse TSCPC, endocyclophotocoagulation, or anterior retinal cryotherapy. These are done when there is poor visual outcome or when other methods have failed to control the intraocular pressure. So in conclusion, the ophthalmology community should work synergistically across specialties and with patients to surmount barriers to optimal NVG. It is crucial to look at the cause of the NVG at diagnosis, and primary cause, ischemia, inflammation, and systemic issues have to be addressed simultaneously. So everything is very important. Meticulous examination, timely decision making, multidisciplinary approach, and aggressive management is mandatory for ideal outcome. Thank you.
Thank you, Dr. Asha. So next I call upon Dr. Rachel to present her talk on steroid and raised IOP.
I think anti-VEGFs have actually changed our management of neovascular glaucoma. It is no longer associated with poor prognosis like it used to be before, and we can achieve very good control of intraocular pressure and salvage vision. So one should not delay surgical intervention. And anti-VEGF before surgery is very, very important, and it has been proven many times over in literature. There is no controversy about the use of anti-VEGFs in neovascular glaucoma.
Okay, good afternoon, everyone. I would like to thank BOS for this opportunity to be able to give this talk on steroid-induced glaucoma. So to define steroid-induced glaucoma, it's basically defined as an elevated intraocular pressure, usually more than 10 millimeters of mercury, along with the glaucomatous optic neuropathy. And this is in the setting of a corticosteroid use. So it is a major cause of avoidable and but irreversible blindness. But of course, if we intervene early, then probably we can halt the progression of the disease. The easy availability, the low cost, immediate relief of symptoms, self-medication, etc., some of the causes which have led to the widespread use as well as the misuse of the steroid. Now, the magnitude of the problem is actually huge. There have been several studies which were conducted in various centers, and it was done more in the pediatric population on children with VKC. So the incidence of steroid-induced glaucoma was between 2 to 4%, and the percentage of children who became blind, at least in one eye, was almost between 32 to 37. So definitely it is a huge problem before us. The steroid response, so people who exhibit a response are known as steroid responders. So it could be high, intermediate, or non-responders depending on the magnitude of the IOP rise. So if it is more than 15 millimeters, he is classified as a high responder, between 6 to 15 as an intermediate, and non-responders if the intraocular pressure is less than 6. So this basically highlights the fact that we need to establish a baseline or check the intraocular pressure before starting the patient on steroids. And irrespective of the magnitude, whatever is the type of steroid response, if the patient responds, that means he is at a higher risk of developing steroid-induced glaucoma. So the individuals at risk for developing steroid-induced glaucoma are pre-existent primary open-angle patients, glaucoma suspects, first-degree relatives, children especially where the response is very rapid and severe, type 1 diabetes, connective tissue disorders like rheumatoid arthritis, high myopia. Post-refractive surgery patients are also, so you have confounders which give a falsely low IOP because the corneas are thin as well as the low scleral rigidity. Pigment dispersion, angle recession are other risk factors for developing a response. So a brief about the pathogenesis, it's basically there is an increase in the extracellular matrix. So this is because of the accumulation of the glycosaminoglycans. Then the rho kinase protein also has been implicated in the pathogenesis. So it causes an alteration in the trabecular meshwork contractility. So again resulting in a low outflow and increase in the pressure. There is also a genetic predisposition because this has been identified in individuals having the myocillin gene. So it is a multifactorial etiology of steroid-induced glaucoma. And what are the factors which determine the severity of glaucoma? So one would be the potency of the steroid use, the duration of the use, the dosage with which it is administered, as well as the routes of administration. Knowing the IOP elevations of different steroid preparations enables us to be able to make a judicious choice as to what kind of steroid to prescribe to the patient, especially in the risk individuals. So, and this, the drugs like dexamethasone, prednisolone, and difluprednate, they are the higher potency steroids. So, the pressure rise is almost between 10 to 22 millimeters of mercury, whereas the weaker steroids like fluoromethalone and loteprednol, the propensity is between 2 to 6 millimeters of mercury. There are multiple modes of administration, exogenous as well as endogenous. So in the ophthalmic preparations itself, the steroids can be administered topically, then with the help of subconjunctivally, intravitreally. And the non-ophthalmic could be as nasal sprays, the inhalers, as systemic, as dermatological creams, and also as IV and as tablets. Another uncommon but possible cause of steroid exposure could be an endogenous source. So, with the adrenal gland hyperplasias or carcinomas also, and certain pituitary tumors also could result in an endogenous steroid exposure. So the most frequently used steroids will be in the topical form used for a wide variety of anterior segment conditions. So here the IOP response is usually it can occur immediately or can occur within 3 to 6 weeks following a topical steroid use, and it returns to normal on cessation of the drug and within about 2 weeks. So a high index of suspicion again in the at-risk individuals. Periocular steroid injections, again, we are using in a wide variety of intermediate uveitis. So here the type of IOP response is of a delayed onset. So the mean is between 9.4 weeks to 3.2 months, is multiple studies have shown. And the IOP response is of a longer duration. The hypertensive response is higher compared to the intravitreal steroids. Subconjunctival injections are also given to treat VKC in the supratarsal form. So all these have a higher IOP response. So we need to have this in mind when advising these medications. Intravitreal steroids also are being used extensively to treat a wide variety of posterior segment disorders. So here the individuals at risk, as mentioned earlier, are those with pre-existent glaucoma, eyes which have undergone a vitrectomy, aphakia, the presence of a PCR, patients who need multiple injections, as well as the location of the implant. So it has been seen that if the location of the implant, if it is closer to the ciliary body, there is a higher chance of developing ocular hypertension. And the most commonly used intravitreal steroids are the triamcinolone acetonide and the dexamethasone implant. So we need to know the peak time for the IOP rise. So usually in triamcinolone, it's around 2 to 4 weeks. And whereas in the dexamethasone implant, it is around 6 to 8 weeks. And it has been seen that using both these, the intraocular pressure returns to baseline within about 6 months with the concurrent use of the anti-glaucoma medications. And the Ozurdex implant is associated with a lower frequency of ocular hypertension compared to the IVTA. So how does the patient present? So sometimes he can be asymptomatic, but of course there will be an elevated intraocular pressure and the angles will be open. Blurred vision could be due to the corneal edema or because of posterior subcapsular cataract. There could be visual field changes, disc changes. Children can present with features similar to that of a congenital glaucoma. And another thing which we need to keep in mind is patients who have received steroid treatment and then discontinue it may present as features of normal tension glaucoma. So we always need to rule out a history of steroid use for a long period before labeling the patient as a steroid-induced or a normal tension glaucoma. And of course, the timing of the response is variable. So coming to the management of it, so once a diagnosis has been confirmed, the first and foremost thing is to stop or cessation of the steroid. And in cases like VKC or allergic conjunctivitis, we can stress on the conservative methods like cold compresses, antihistaminics, alternate medications like weaker preparation of steroids, or steroid sparing medications like tacrolimus, cyclosporin, or immunomodulators. And the concurrent medical management which has to be started in these cases, usually the aqueous suppressants will be the first line, like the beta blockers and the calcium carbonic anhydrase inhibitors could be used either systemically or as a form of topical medication. Alpha agonists, again, to be used in caution with children. Rho kinase inhibitors are found to be useful because it has also been implicated in the pathogenesis. And the surgical options include, if a steroid depot has been used, to excise the steroid depot in cases of subtenance, and if suppose the implant also has found to be the implicating factor, a vitrectomy can be done, has been done in certain cases to remove the implant itself. And selective laser trabeculoplasty has found to be effective. MIGS, however, has been shown to be useful in steroid-induced glaucoma, and it has been found in certain studies to be effective in steroid-induced glaucoma of a short duration and a higher baseline IOP. Other options being trabeculectomy and drainage devices, and in refractory cases, cyclodestructive procedures can be tried. So to conclude, prevention is definitely better than cure, and early identification of risk factors is very important to be able to identify the at-risk individuals. Frequent monitoring of the intraocular pressure to detect the spikes, as the spikes can occur at any time, and awareness. So awareness, this also includes the non-ophthalmic physicians regarding the follow-up which is required when they put patients on steroids, as well as counseling to the patients and the caregivers regarding the need for frequent follow-up. Thank you.
Thank you, Dr. Rachel, for covering that extensive topic. I call upon next speaker, Dr.
I'd
Srijana
like to
Shaw.
add a point here. Not to forget the OTC drugs, that is across-the-counter drugs. Here, the patient is unaware what he is consuming. They just go to the pharmacist and they start off with some small pills, especially for prompt relief of systemic conditions. So don't forget this. You are unaware about what the patient is consuming, and glaucoma is a very heavy price to pay for that prompt and fast relief from systemic diseases, especially bronchial asthma. They just go on taking betamethasone, the small tablets which are dispensed by the pharmacist. They don't go to the doctor because it's quite frequent, especially in Bangalore. And I have seen many patients who pay a very heavy price, and they are all very youngsters. So we need to stop that across-the-counter dispensing of steroids.
Good afternoon, everyone. Thank you, BOS, for this opportunity. I'll be talking on management of traumatic glaucoma. So why is this topic important? It's because majority, nearly 65% of the emergency cases that we see in our ophthal OPD is usually trauma. And this usually affects young males or children, and this can have a significant social and economic impact. Usually the mode of injury is again based on the age. Sometimes it can be play injury, sports injury, assault, firecrackers, accidental or workplace or combat injury. So these are the different types of ocular trauma, where mechanical is the most commonly seen trauma, wherein it's either penetrating or a blunt trauma. So when we look at the differential diagnosis of glaucoma after trauma, we can base it into early onset glaucoma or a late onset glaucoma. So first I'll be talking about the management in the early onset glaucoma. So in a blunt trauma, what happens is there's a compressive force where there's an anterior-posterior direction of the force, and as the eyeball cannot increase in volume, it expands equatorially, leading to the tears in the equatorial region. That's the 7 signs of Campbell. So when we see in our OPD, we see these kind of, very commonly we see these kind of patients where there's contusion injuries, there's hydrodialysis, there's a lot of inflammation, sphincter tears. So the first thing that we have to do is check the mode of injury. Was it a blunt trauma, penetrating, chemical, thermal, what kind of injury? Document the injury, have it very detailed because this can go into medico-legal aspects. Check for CDLs, document the vision. Contusion injury, most commonly it's mainly the soft tissue injury, which can lead to a lot of edema, and this can raise the intraorbital pressure also in severe cases. The increased intraocular pressure in these acute traumas are most commonly due to the inflammatory cells or debris, which is blocking the trabecular meshwork, thereby reducing the aqueous outflow. We have to always avoid gonioscopy in acute injury because this can actually lead to bleeding. So how can we manage this? This is usually managed with corticosteroids, cycloplegics, and aqueous suppressants. Always avoid miotics and prostaglandin analogs when we're using the medications. So one of the most important things that we can see is a hyphema. So the traumatic hyphema is mainly because of tears in the iris or the ciliary body vessels. And this can range from very minimal hyphema, less than 1/3 of the AC filled with the blood, to even complete AC being filled with blood, or even an 8-ball hyphema, which is clotted blood, and this is something very dangerous. In long-standing cases, if hyphema is not treated, it can lead to even corneal blood staining. So in normal patients with normal hemoglobin, the greatest concern that we have is for the secondary IOP elevation that can occur due to rebleeding. So this occurs mainly in the first week because when the clot retracts. So this is commonly seen as a clotted blood, and there is fresh bleeding above this level. In sickle cell anemias, these patients are at risk for higher risk of optic nerve damage because they can have acute spike in IOP and even CRAO. So how do we manage traumatic hyphema? The first thing that we do is conservative management with bed rest, limit the activities, head elevation, and an eye shield so that we don't have the chances of rebleed. In medical management, we start off with corticosteroids to decrease the inflammation, cycloplegics to control the spasm, aqueous suppressants. One thing about aqueous suppressants is avoid miotics, prostaglandin analogs, and also carbonic anhydrase inhibitors in sickle cell anemia, because this can induce acidosis and increase the sickling and acute rise in pressure. Systemic antifibrinolytics can be used like aminocaproic acid or tranexamic acid, but these can have systemic effects like hypotension. So this has to be taken with care. Surgical management. When do we actually intervene surgically? This is mainly when the IOP is persistently high for above 50 mm of Hg for 5 days or with a total hyphema, or even 24 mm of Hg for even 24 hours in sickling patients, IOP of more than 35 mg for 7 days, or large stagnant clot for 9 days, or when there is corneal blood staining. So the surgical management, firstly, we can do a simple anterior chamber washout, irrigation and aspiration of the clot. We can even use phaco energy to actually remove the clot. When large clots are present, we can actually deliver the clot with a limbal expression of the blood clot, but this is usually not very preferred because it leads to a lot of large excision at the limbal area. In cases in patients who already have primary open-angle glaucomas are at risk of developing optic nerve damage, we'll have to even try trabeculectomy or a glaucoma drainage device. One thing that has to be kept in mind is surgical intervention, we have to wait at least for 3 to 5 days before intervening until the clot retracts. And also when we are removing the clot, to avoid tugging on the clot, because this can again open up the blood vessels leading to rebleeds. When we look at late onset glaucoma, the most commonly thing that we see is angle recession glaucoma. So in angle recession glaucoma, the first thing that we need to remember is that any case of unilateral secondary glaucoma always have a high index of suspicion, because a lot of times patients may have forgotten the history of injury if it's many years back, because angle recession glaucoma can occur even 2 months after the injury or even 10 years after injury. In cases of unilateral glaucoma, a raised IOP in one eye or ipsilateral deep anterior chamber, this is something that we have to keep in mind. Any case with more than 180 degrees of angle recession has more chance of developing glaucoma. This is mainly where there's a separation of longitudinal and circular muscles of the ciliary body, and it's been found that there's a strong association in cases where there's been a traumatic hyphema. They usually even have angle recession. So always do the gonioscopy after the hyphema has resolved. On gonioscopy, we can see an irregularly wide ciliary body band, and there's a retroplacement of the iris root. So that angle appears abnormally deep. Always compare with the fellow eye. Do the fellow eye gonioscopy first and then the affected eye. So when there's a case of trauma and it's an old trauma, we should look for other signs of features of trauma like sphincter tears, traumatic mydriasis, iridodialysis, Vossius ring, zonular dialysis, and traumatic cataract. So this can also tell us that probably there is an angle recession in the quadrant where there's been a sphincter tear. In management of angle recession, we first start off with medical management with aqueous suppressants, and PG analogs are usually given in these cases because it increases the uveoscleral outflow. Again, avoid miotics. The response to medical treatment is a lot of times variable, and in refractory cases, we definitely do need surgery. Laser is definitely not indicated in angle recession glaucoma. Surgical management, trabeculectomy with MMC has improved the success rate, but definitely it is slightly lower than the POAG success rate. Glaucoma drainage devices are reserved for patients who have poor conjunctival health, and cyclodestructive procedures are for those with limited visual potential. When we have to follow up angle recessions without glaucoma, if it is less than 180 degrees of angle recession, yearly follow-up is sufficient. If it's more than 180 degrees of angle recession, 6 monthly follow-up is recommended. Now the other forms which are slightly rarer is ghost cell glaucoma, where we see this typical candy stripe appearance of the khaki cells which are layered with the blood cells. This is seen when there's a vitreous hemorrhage and these degenerate RBCs come forward into the anterior chamber. In refractory cases, we will need an AC wash with a PPV. In cases of lens-induced, it can be subluxation, dislocation, or lens particle glaucoma, and the cataract has to be managed. In rare cases, it can even have a pupillary block, which may need a PI. In a cyclodialysis cleft, there's hypotony initially, but once the cyclodialysis cleft closes, it can lead to high pressures, and this is usually seen when the outflow mechanism is also affected. Epithelial downgrowth is seen in any penetrating injury or surgical injury. And intraocular foreign body, we have to have a high index of suspicion in later stages in case you're seeing other signs. Like in case it's an iron foreign body, look for other signs like mydriasis, pigmentation, or heterochromia. Always look for the intraocular foreign body even in the angle, especially when you have an entry wound on the cornea, if there's a small scar, if there's a small hole in the iris also. In conclusion, the key points in management of traumatic glaucoma is, if you can find out the cause for the glaucoma, treat it medically. If medically it's not possible, treat it surgically with trabeculectomy or with GDD. In case it's adequately treated medically, then start stepping down the treatment. In case the cause is not ascertained, always look for rarer cases of high pressures in these cases. So it could be ghost cell glaucoma, it can be a Schwartz syndrome in RRD patients, corticosteroid-induced glaucoma, cyclodialysis cleft closure, or sometimes even primary glaucomas. So concluding, glaucoma due to trauma is complicated with its acute and chronic manifestations. So once the acute situation is rectified, it's always important to educate the patient that the raised IOP can occur at any time in their lifetime, so regular follow-up is mandatory. A careful history and complete examination is especially important in those cases where you're seeing only unilateral glaucomas. In addition, all patients with very severe injury, it's important to tell them to monitor regularly for raised IOPs. Thank you.
Thank you, Dr. Sujani, for bringing out very salient points of commonly occurring glaucoma that we come across. I now call upon Dr. Anuradha to speak on patient counseling in glaucoma. Again, a very important topic.
Regarding hyphema, bleeds and rebleeds, you take a careful history from the patient. Is the patient on any systemic drugs? Because blood thinners, most of the elderly patients, trauma is one of the cause for the hyphema. But then you have to ascertain why the rebleed. Sometimes it will be non-resolving hyphema. Then you have to take a history where the patient was on long term of aspirin. Then the trauma-related hyphema was one aspect of it. And then the systemic disease, the blood thinners were the cause for rebleed. So you need to assess that also. Keep in mind.
When do you do gonioscopy after a blunt trauma? That is one question probably.
Blunt trauma, I mean, if the AC does not have any hyphema, a gentle 4-mirror gonioscopy we can do. I mean, it is not contraindicated, but look for occult signs of globe rupture. I mean, you know, the low IOP and other things, and there you should be extra careful. But now that we do routinely 4-mirror gonioscopy, I think we need not have that kind of inhibition to do gonioscopy. If there is hyphema, obvious that you won't see anything. wait till the hyphema clears and then do the gonioscopy. I mean, these cases can be quite difficult. I think all of us have experienced that. And the threshold to intervene surgically, I would disagree with what the rules that you mentioned, because 50 millimeters for 5 days is enough to cause optic atrophy. We should not wait for the patient to go into optic atrophy to intervene. So if your medical management is not showing a downward trend of the IOP. So if the pressure is 50 on one day and I have given maximal treatment and the next day it is in the 30s, then I know this glaucoma is responding. On the other hand, if it is 50 and I give maximal treatment, give mannitol, do everything, and the pressure does not budge below 50, and that is remaining for a couple of days, I would go in and intervene. So I differ on that aspect, that our decision to operate should be based on the individual patient, and we should not withhold surgical intervention.
Only thing is that when we do an AC wash, there is always a chance of reactionary secondary bleed. So that is something which we should keep in mind. And another thing is, sometimes the bleed might be happening from an iris root, where there is a small iridodialysis which we would not have seen in the slit lamp in the OPD. So when we try to pull these clot, we have to be very careful that we are not injuring the iris root more.
And for the same reason, visco expression and all that is not, though it has been described, practically one would not do such things. I would err towards doing a trabeculectomy, leaving the blood clot in the AC and not pulling it. So even that trabeculectomy may fail in the long run, but at least immediate post-operative and the intervening period, the pressure will be low. I think we'll go ahead.
Yes, ma'am. Good afternoon, seniors and friends. Thank you, BOS. So we'll talk on counseling patients with glaucoma. A very, very important topic according to me. Glaucoma being the second most common cause for blindness, which is irreversible, and thereby glaucoma related blindness mainly is due to the compliance issue in a patient. So what are some of the poor compliance and poor follow-ups? It's because they don't understand the disease properly and its management. There is perception that there is no problem in their eye because the central vision is maintained, only the periphery is affected to begin with, and false notions about the need for follow-up, and belief that medication is not doing any good to a patient. So what exactly is counseling? So here we are providing medication information orally or written form to the patient and the representatives on the direction of use, advice on side effects, precautions, storage, diet, and lifestyle modification. Is it really important? According to us, yes, because glaucoma causes irreversible blindness, and the minute we explain the disease to the patient, they have mental issues. They start worrying too much about the disease itself, even if it is in the beginning stage, and therefore we have to provide a balanced information to a patient, because all this will contribute to improve the patient's quality of life. So the entire purpose of counseling in glaucoma, first we have to talk about the disease itself and its implication on the vision, the need for medical therapy and its regular follow-ups to improve patients' compliance with the medical therapy, and when we talk about surgical management, what are the options available, and what are the alternative options. And last will be low vision. So the minute we are going to tell that, we are going to tell them everything, lot of patients will start Googling, okay? And then once there is all this information, there's a lot of confusion, and thereby the patient is overloaded with the information, so which we have to provide and counsel in a proper way. So there is one counseling wherein there is adapted motivational interviewing, wherein first we talk about how much a patient knows, okay? After first follow-up, we can always talk as to how much patient knows and then educate the patient appropriately. And in very advanced cases, there is a phenomena called as Charles Bonnet syndrome. That is, they are seeing some pictures which are not visible to others, or which do not exist. So sometimes most of them don't talk about it because we might, patient will think that, he is abnormal. So they don't talk about it. So there are such phenomena whereas it is also called as visual release hallucination. So these are the people who, there is no medication for this. These are the people who might need low vision aids. So what exactly should we do? First thing is a glaucoma consultant should have a lot of patience, have listening ears, be firm, empathetic, sympathetic, and we have to tell everything that we have to tell, but in a very polite manner, and we should not hide information. We should not give over-promising results, should not be guaranteed, and there's no way, like we cannot get frustrated. Sometimes they might not use the drops, or they would have used only one vial and then they wouldn't have purchased it. So every time there is something that we unearth with every visit, so please don't get angry. Treat every patient as a different and separate individual. We have to be legally correct, and therefore documentation is the only thing that we can do here, and support with photographs whenever possible. So suddenly some patient comes to us, after we would have seen the patient, we would have told everything, and then they're lost for follow-up. So please treat these patients as new patients, rework up again, and then restart them on therapy. Develop a good rapport and trust. Allow patients to express their concerns and questions, and if non-compliant, we can always find a reason, and then we can ask them to suggest to what can be the alternative method and how to improve the compliance. So what medications are being used and how often? Every time we have to check on it, and we have to probably give them some kind of labeling when they cannot understand. And also always address the side effects, because these medications have lot of ocular surface side effects, okay? And then suddenly some patients, they'll say, "Kan kempaitu," so we stopped, okay? There are itching aitu, so we stopped. It's very, very common. So it is our responsibility to deal with all this and explain and treat them. And glaucoma is one disease wherein they'll have lot of medications with lot of brands being used, okay? So they get confused also. So it's better that we teach them some kind of labeling or some kind of diaries to be maintained. They will do it if we tell them that it's available. A simple notebook is more than enough, but then we'll have to explain it to them. And counseling regarding the surgery, it cannot be overemphasized the fact that we do the surgeries only for the IOP control and to prevent the further progression or slow the progression rather. There's no way that we can handle it at the optic nerve level, okay? And there is no way that we should be giving them over promising the results, okay? So we should be very, very frank about this part. And the worst thing is when they come with different attenders, even after surgery, they tell us that ಏನು ಕಾಣ್ತಿಲ್ಲ, okay? It is different from cataract surgery, so we have to emphasize the fact in pre-op period. We have to give them enough time to accept that. There are various surgeries for glaucoma, and before every surgery, we should see that we explain everything, because these are surgeries which have high failure rate. We might have to do multiple surgeries, we might have to do alternate surgery at a later date. So we'll have to explain about resurgeries as well. Sorry. So also keep in mind that there are a lot of drug allergies in each patient. There can be different. So please inquire about it before starting on any particular medication. And we all know that it runs in families. So the minute we are going to tell about this, again, there is a panic button. So talk about it, see that you screen their families. And last will be low vision aids and rehabilitation where required. Emphasis is needed for long-term follow-up. Can I get some water? Sorry, I'm ending.
Anuradha is speaking about a very, very important topic. We can't overemphasize the importance of this counseling.
I'm sorry. Sorry, counseling empowers a patient to take a active role. Can be understanding of a disease, better adherence and compliance, emotional and psychological impact is needed, and then detect and address potential barriers. Thank you.
Dr. Anuradha, that was a very nice presentation, and I think all of us here have enjoyed that. Any doubts from the audience? I think we can take quickly a few questions if Shilpa allows.
Thank you all the speakers for sticking to the time. Any questions from the audience?
Always intravitreal. See, the turnaround time for the aqueous humor is very fast. So if you give it intracamerally, it is going to be washed out of the eye. Always give it intravitreal. PRP can be done concurrently. I mean, either you don't need to wait. But for a surgery, glaucoma surgery, either trab or tube, preferably 48 hours beforehand for the anti-VEGF to act or start acting. Yes, Sujan.
So in a patient who works throughout the night and the patient has been put on PG analogs, when would we ask them to use the PG analog? Like he doesn't sleep during the rest, when he switch on to a different...
Yeah. What Dr. Sujani is asking is if a person works through the night, when do we give the PG analog? I know the traditional teaching is that it's given at night, but it is not a strict dictum that we need to follow. I am not aware of any study which compares, say, morning application to evening application, and without any doubt proves that night application is the one which is superior. These were the ways in which the trials were conducted, and that is why we are continuing it. And in large majority, it's convenient to put it at night. So having said that, for any patient where their daily routine is such that it is inconvenient, why not in the morning? Absolutely, it has not got any relationship with the autonomic nervous system and sleep-related changes like the beta blockers do. So I think we can shift it. But when it is combined with a beta blocker, when we give a combination of a PG analog and a beta blocker, I would say preferably in the morning, because we know that the beta blocker component may not work quite well at night.
It's the OD dosage of prostaglandin analogs when a mono drug is used that was considered. But then for convenience, we said it is better to use it at night. So I think it has nothing to do with the circadian rhythm. Does it have a role in the
the initial publications which came out when PG analogs were new, all stressed on the nighttime application, because that was
started off with
No, that was supposed to blunt the nighttime elevation of the intraocular pressure. There is a certain rationale. But then there are no clear-cut studies which has compared, say, morning dosing and night dosing and said that definitely morning dosing is inferior or vice versa. So I think we can use our, judgment, and patient convenience is very important. I mean, if it is something that patient finds inconvenient, he or she is likely to stop and become non-compliant. So we need not stick to that evening or nighttime dosage. Shilpa, we should conclude. I think we should leave time for lunch. Thank you so much, all of you, for staying back and, foregoing lunch time.
Thank you, BOS, for giving us an opportunity to interact with all the consultants, glaucoma consultants. Wishing best.